Hi, everyone. Welcome once again to our weekly webinar on preventing and managing COVID-19 in the workplace. This is Karen O'Hara. I'm the Director of Marketing and Communications with WorkCare. Welcome once again. If you're a regular attendee, you know our routine. For those of you who are just joining us, I just want to remind you that the session is being recorded and you'll be on mute for the duration of the webinar. But you can submit your questions using the Q&A function at any time, and we'll address as many of them as we can in the time we have allowed. We always post answers to questions on our website on the COVID resources page, which you can find at workcare.com, and we post a recording on our YouTube channel. Before we get started, I just wanted to give a special shout out to Alexis, who joins us every week and helps us put on the webinar, and she's making extra special effort today because she's in Texas and she has no power. She's boiling her water and she's freezing down there. They have no heat. So I just wanted to mention that we really appreciate her being here for us today. I'd like to introduce you to our speaker, Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He's WorkCare's Chief Innovation Officer and Associate Medical Director. He's also our lead clinician for our COVID-19 response. And those of you who've heard him from week to week know he's just a great resource. So I'll turn it over to him. Thanks again for joining us.
Excellent. Thank you, Karen. And thanks everyone for joining us once again. I echo your sentiments, Karen, in regards to Alexis and her dedication to helping us put this on week after week now, almost for a full year. So thank you and kudos. So we'll jump into our agenda for today, a lot to unpack today. You know our format if you're joining us again. If you're not, we'll go into the clinical update first, followed by some pathology, microbiology updates. We'll talk about our epidemiology picture in the US and abroad, finally getting to our prevention and our trends that are happening, both macro and micro, and then finally our workforce strategy that we want to partner with you on the WorkCare offerings, as well as offerings that are available in from other venues. So without further ado, today we're going to be talking about, for our clinical presentation, the risk of reinfection. And this is something that has been making more popular news recently over the last, I'd say, month or so. And it's a result of emergence of these variants that can pose a risk for our population, our workforce, not just in regards to reinfection, but also increased risk for poor outcomes, severe disease, as well as mortality. And we touched upon this in previous about 2 sessions ago, I believe, and looked at some of the strains that are leading to an increase in mortality and to be mindful of it so that we are taking extra precautions. And as we dig into it today and we talk about the reinfection rate in the US, this is what is playing out, right? Very recently here in terms of an underestimation of COVID-19 reinfection rates in the US. And as we look at what the CDC wants to suggest around reinfection, it ain't much, right? The CDC has said when they did this update here some time ago last year, that yes, we know reinfections can happen. We know that there are a number of factors that play into that in terms of potential likelihood, how often, frequency, and the settings for reinfection, right? Who might get reinfected at a higher risk. And we know that reinfection documentation-wise is occurring, but still at a low rate. But again, if we look at the opportunity to capture and articulate reinfections in the US, we might be missing the boat substantially, is what is starting to gain momentum in terms of clinical understanding in the clinical community. So as we look at some publications around reinfections, we can start to unpack what is a potential driver for reinfections. And this particular publication, pre-publication, looked at past infections of individuals who did have 83% protection over a 5-month period to prevent reinfection. All right, and obviously 83% is lower than some of the percentages that we engender from vaccinations, up to 95%. So it is some concern in terms of reinfection rate after natural immunity. And so this particular instance, when again, looking at those who previously infected with COVID-19 still carried the virus in their nostrils and potentially were able to transmit it to others, okay? And so that plays a factor in regards to reinfection rate, where we're speaking to carriers of the virus that may at some point develop a secondary infection or transmit it to those who may be susceptible and don't have immunity to SARS-CoV-2, all right? And this particular study was looking at thousands of healthcare workers that were tested out of England. And then when we look at, furthermore, the study that took place between June and November of last year, 44 potential reinfections were documented out of 409, right? That's quite a bit if we were talking about reinfections globally that have been confirmed to date. And we'll dig into those numbers and see what they look like here shortly. But again, evidence pointing towards a higher number, albeit not super high, but reinfection rates happening more frequently than we previously believed them to do. If we look at other instances that were detailed in this examination here, Washington State is currently investigating 700 potential cases of reinfection, right? And they're awaiting genetic sequencing. Colorado, similar case here, 400 potential reinfections. Again, small number, 0.1% of positives of coronavirus, but because of the high number of prevalence, 396,000 cases in Colorado in particular, that's still a considerable number of reinfections. And again, when we talk about documenting and confirming these reinfections, there are a couple of bottlenecks that need to be considered. When we look at Washington State's approach to epidemiology and understanding the reinfection rate, it's all about genotyping, right? And what we know is that in the US currently, genotyping is happening at a considerably low rate. We're only talking about a couple hundred genotypes nationally with the laboratories that we currently have capabilities to do genotyping of confirmed cases, samples of confirmed cases. And that genotyping, again, is something that is critical to understanding the emergence of not just reinfections, but also variants as well. And so the Biden administration, CDC, has committed to increasing that number from several hundred to several thousand tests. And these tests are essentially, again, coming from laboratories that are confirming COVID positive cases and sending those, holding on to those samples and sending those samples to the CDC. It's a former program that's been around since last year and now is getting more resources to increase that particular program. And we can touch on that particular program in subsequent talks here. But again, the important thing is it's all about genotyping so that we can begin to more accurately understand the reinfection rate for COVID-19 in the workplace, as well as obviously the general population, particularly as we see these new variants play out. So let's dig into some of the pathology by examining now the number of cases and reported in the US, potential cases and confirmed cases, okay? And this then gets down to the detail of where these cases are happening and also the suspected cases numbers total. And that is about 11,000 cases suspected for reinfection in the US as of February 12th of this year. And if we look at where they're occurring in all the states that we know are being hit hard by both variants as well as just total number, Texas, Florida, Colorado, Arizona, okay? And so we can continue to watch these cases and see if they are suspected, probable, or confirmed cases as we move forward. This will give us an accurate picture, again, of our relative risk for our workforce in terms of those individuals who have become infected with COVID, let's say mid last year or even in the fall, outside of that 3 to 5 month window and present potentially an increased risk of reinfection. Okay, again, understanding this picture more accurately will help us in our preventative efforts and how we move forward with quarantine, etc. If we look at confirmed cases, then only 49 confirmed cases, according to this study, again, tracking confirmed cases in the US, is a matter of genetic profiling of the potential reinfections. And this study is looking at globally the number of cases. Again, not a tremendous number, but the bottleneck still remains is the genetic profiling of these potential reinfections. If we look at then some news out of a study done in South Africa, and this is regarding a genetic variant that we have become more concerned about, which is the South African variant. The likelihood that the virus is going to escape immune response is something that has been detailed more fully over the last several weeks, meaning that if I contract the African variant and I have natural immunity from SARS-CoV-2, what's the likelihood that I will then contract again COVID as a result of this novel variant? And we're seeing that for those individuals with natural immunity, there is an increased risk of contracting the novel variant from South Africa versus a vaccine-derived immunity for individuals. In this particular case, the phase 3 UK trial looked at 50% of the cases that were attributed to the novel UK variant, and we were able to see that the Novavax vaccine protected against it, as well as what happened with the South African variant as well, 90% efficaciousness. So this is positive news in regards to the efficaciousness of vaccines that are not just the Novavax, but other vaccines on the market currently, and their likelihood to protect from these variants. However, again, natural immunity is now being shown to be not as effective for protecting against this particular variant, the South African variant. So we'll see more data pour from this study and other vaccine trials as we move forward here. Now looking at the numbers from perspective of where do we stand today. I know you all have seen the numbers high level in terms of decreasing incidence in the US, and we'll talk about that trend and try to fully unpack why we see and how we see that trend. If we look at where we were last week in terms of the per 100,000 cases, 33.5 is where we stood with a total of 26, almost 27 million cases, and that increased over 27 million to 27.5 and decreased the rate per 100,000 down to 25.9. All right. If we're looking at deaths now, we're talking that 0.9 per 100,000 in terms of death rate, went from 463,000 deaths, still at 0.9, but up to 485,000 deaths attributed to SARS-CoV-2 in the US here. If we go on to look at more globally how the US is faring against our neighbors in regards to cases, we are seeing and continuing to see that downward trend on a 7-day rolling average here in the US. That downward trend continues with our neighbors in France, the UK, as well in Spain. So we're seeing globally this decrease in overall cases, which may be a good sign. We'll see, and we'll talk about that more here. That's where we stood last week. This is where we stood this week with that continued trend, downward trend at this point under 100,000. Again, last week we were over 100,000 trend, this week below 100,000, all right? And if we look at then cases per million, we're seeing similarly a downward trend for the US, downward trend for the UK, Spain, and others in regards to cases per million. We're at right around that 370 mark in terms of 7-day rolling average last week, and that downward trend continuing for us with the US towards that 200 number, right? So just over 200 on a 7-day rolling average per million cases in the US. All right, there's obviously some, again, positivity there, but we'll look to see how realistic it is in a second. If we look at deaths, we're seeing that 30-day trailing indicator of deaths last week trend downward and continue to trend downward considerably this week as well. And that obviously is a good indicator. If we look at deaths per million, we see the UK trending down. Unfortunately, Spain still trending up if we're talking about the number here. So we'll look at it from the US standpoint, trending down over time last week, and where we stand this week, deaths per million, continuing to trend downward. Now we're talking about the tests here, right? Looking at the tests, when we talk about the total number of tests for the US, that number has been trending downward, as you've seen over the last couple weeks. And we unfortunately continue to trend downward over the last couple weeks here. And that downward trend is an indication that we don't have a full understanding of the incidence here in the US, right? And so when we talk about what's happening across the pond in the UK, they're basically plateauing a little bit here on their number of tests. If we look at France and Germany and other nations, again, they're kind of plateauing. They aren't decreasing in the number of tests on a 7-day rolling average. Looking at that per 100,000, again, seeing what our neighbors are doing, still plateauing, and in some cases with the UK, increasing in their number of tests per 100,000. Again, more accurately articulating burden of illness compared to us in the US that has this downward trend. That is concerning from an accuracy standpoint of, are we actually seeing the decreases or declines in incidence that our numbers are showing at a high level? If we look at then where we stand today, we continue to see that downward trend, UK seeing that plateau or a little increase in their trend. The positivity rate is important to look at too. Now, we know that when this trend is going upward, we're seeing less accurate picture of what the burden of illness is in the US. For us, it has been decreasing, but not tremendously over time. And if we look at where we were last week versus this week, we do continue to see that downward trend in positivity rate. So it may not be ominous in terms of the decreased number of tests that we're seeing on the 7-day rolling average, speaking to poor understanding of the burden of illness. And it may be true that we actually are making some progress towards a greater number of people experiencing less incidence of disease. And we will unpack that more deeply next week when we get down to determining what is the prevalence of natural immunity versus prevalence of vaccine immunity. And we can glean some of that today as we look at our rates of vaccinations as we will right now. So last week where we stood, total number, US leading the way. If we look at where UK was last week, in second place there, and we see where we are this week. So we went from a little over 1.4 million, again, to well over 1.6, almost 1.7 million administered doses. Then we continue to look at that from a per 100 individuals. We see where we stand comparatively last week, and then zero in on where we stand this week with an upward trend per 100 individuals with regard to vaccination administration. So that total number last week was 62, almost 63 million distributed doses versus 43 million administered doses. And Pfizer and Moderna still at that ratio of almost being even there. And this week, up to 71 million now administered distributed doses and 55 million administered. So if we look at that ratio, still relatively similar in terms of that ratio of distributed or delivered versus administered vaccines. So when we talk about the Moderna versus Pfizer, we continue to see that trend of Pfizer leading the way a little bit further, and that's okay. That's to be expected. Again, the efficacy being very similar for these two, so no concerns from that standpoint. Now let's look at the history and lineage of the different variants as they present in the US here. We did an update of this a couple weeks ago. Doing an update today, I think, is important as we talk about trends and potential impact, right, regarding reinfection. So if we look at B117, that's the UK version, we see that 1,200 cases reported here in the US, and we can see where those cases are mostly reported, California and Florida. versus the South African variant, which is the B1351, and then the variant that was identified originally out of Brazil, but it was in Japan where they first found it, the P1 variant. And we can watch these over time because, again, these variants may represent both, well, they definitely represent increased transmissibility, right? We know the South African variant, as well as the UK, had in some cases up to a 40x increase in transmissibility for the virus itself. And then obviously the increased risk of death for the documented 117, and then resistance potentially to natural immunity from the South African variant. So important to know, important to see how this plays out in regards to reinfection and strategy. So one of the things we want to pay attention to in terms of trends and opportunity to increase our preventative efforts and focus them is data that we can examine from CDC, looking at on a county-based process where susceptibility or vulnerability lies for our workforce. Okay, and we're going to dig into this in a little detail here just to make sure you fully understand how to leverage this data in regards to protecting your workforce and where to allocate resources. We did touch upon a similar methodology with a different set of data months ago, last year, right? And so this is more or less an update with new data that helps us understand, again, what populations in our workforce should have the most attention in regards to our resources to help protect them, obviously layering in the business operations importance with that data. So when we talk about this data coming out of the NIH and their effort to articulate vulnerability for populations, there are a number of factors that come into play, right? One of those, so we'll look at those factors in high level here. That's infection rate, population concentration, intervention method measures of that particular locale, and then the health in the environment. All right, and we'll dig into each of these in detail, starting with the transmission rate here. So the transmissible cases, when we talk about the play into overall rating of vulnerability of a community, the population size divided by the number of cases on a 14-day rolling average or last 14 days is how this data was put together, right? Because we want to look at that period of infectiousness, which is that 10 to 14-day window. If we look at disease spread, then we're looking at the fractional total of cases during that last 14-day period, which is again the incubation period for SARS-CoV-2. And as we look at this metric, it is between 0 and 1. Lower values mean that there's little growth, little to zero growth. Value towards 1 means that there's exponential growth, and it's concerning from a disease spread standpoint. If we look at population concentration in this method, we look at population mobility, estimating daytime population, and the daytime population being a consideration for how many people are out and about, how many people are going to be close together in proximity to each other in that particular geographic, in that county, right? And that plays a role in increased transmission. We know this to be true from looking at the reproductive rate, there are not of SARS-CoV-2 in that geographic. If we look at average traffic volume, so literally how many cars are out in the streets, and we know that that is an indicator of increased risk of infection through transmission because of the number of people out and about. And finally, with this population concentration, looking at the data on residential density, right? What is the actual population density of not just people living in a particular geographic, but how many multi-unit structures are there? How many are in an overcrowded scenario in that particular geographic? How many don't have vehicles, right? So those all play into a role of vulnerabilities for a particular community. Additional metrics used in this consideration is intervention measures for that particular locale, right? Are there social distancing measures being taken, and how considerable are those social distancing methods? And if they're not substantial, that increases the risk potentially for transmission in that community. And if we look at then testing, the number of tests conducted per that population is a metric that can tell us, one, obviously, how that, in this case, at the state level, is the data that we have thus far with this NIH approach. but yet and still, lower rates of testing mean increased potential rates of infection because those are cases that are undetected, all right? That increases overall risk. And the final metric is a lengthy one, looking at health and the environment. And so we'll quickly unpack this. We won't spend too much time digging in because most of this is self-explanatory for the most part. So if we look at the population demographics, both Blacks and Native, we want to look at in terms of increased risk for transmission with those particular populations. Air pollution is another consideration to look at in this factor. If we look at then other considerations, age distribution plays a role, as you know, in terms of poor outcome and susceptibility, and in this case, will play a role in the vulnerability tracking in this NIH study. Comorbidities such as premature death, smoking, diabetes in the community, again, plays a role in the vulnerabilities. And then looking at health disparities, and this will be the last metric we break down here. So the health disparities and the hospital beds are something that, again, we know to be true from a health disparity discrepancy of a community being more deeply affected by SARS-CoV-2 and the socioeconomic status of that community as well. And then finally, the number of hospital beds speaks towards potential poor outcomes because of lack of access. So if we take this into consideration in terms of looking at on a county basis, our workforce, the locations in which our workforce exists, how do we then approach using this data, our strategy in a way that's going to be the most protective, right? That balances risk reward and ROI from a strategy standpoint. Well, as you would imagine, it's not much different than what we've been talking about before, right? We just need to double down on our efforts because, again, with the prospect of variants emerging and potentially becoming the dominant means of transmission in the U.S., we may see more prevalence of these variants leading towards higher cases than we're seeing now, than we're capturing now. And be mindful too that reinfection rate underestimating is likely happening because cases aren't severe when reinfection does occur, right? And so the importance of that is someone who has contracted previously and recovered may get reinfected and may transmit due to that reinfection without knowing, right? They don't screen positive on the daily screen that you may be conducting. They're not symptomatic or mildly symptomatic, right? And so they're showing up and potentially transmitting COVID-19 in the workplace at a rate that may be increasing as we see an increase in prevalence of these variants. And so obviously continuing to do the daily screen is important to capture those symptomatic individuals and exposure risk. Surveillance testing is going to most likely play out more prominently as we move forward throughout the year, right? Because of the emergence of not just these variants, but increased risk of transmission potential. Surveillance testing, as we've bent the cost curve considerably, may continue to be a way to go for our workforce strategy. The social distance tracking, obviously doing social distance, coaching social distance, but actually tracking social distance in an automated fashion, as we spoke to months ago with a digital touch, so to speak, is going to be likely a staple in how we continue to get through this pandemic this year, right? Again, as we have individuals vaccinated, that still won't change how we do social distancing considerably because we know that it's going to be some time to get the entire workforce and the entire general public to a herd immunity. We'll talk more about that perhaps next week in terms of herd immunity and what that looks like with these new variants. And then environmental prevention, making sure you are paying attention to what your HVAC system looks like, still doubling down on efforts to clean the environment. And again, as we talk about increased susceptibility with these variants, we haven't seen any definitive data yet, but we may see more of a prominence on surfaces than we have in the past with the wild type SARS-CoV-2 historically. And then finally, the return to work and the COVID fitness for duty processes in place will continue to be something that's important to reduce absenteeism in the workplace. And we touched upon this in these topics here briefly last time with regard to vaccine acquisition, helping with logistics and administration. That's still going to play out, still going to be important here as we move forward to the next phases of distribution. The Biden administration confirming that they've secured 300 million doses by June of this year is a good indication that we will have the masses, once available, vaccinated as they participate, right? And scheduling these vaccinations, getting people vaccinated in various states will still continue to be a piecemeal approach, and we're certainly geared up to help in that approach. As we talk about then some of the new recommendations, or repeating some and then introducing a new recommendation around vaccination strategy and what to do thereafter for your workforce, obviously wearing masks is still going to be important, right, to protect those individuals that don't have immunity as a result of vaccination and or are still susceptible to reinfection, right? It can happen. Post-vaccine exposure does not warrant quarantine per CDC just last week now. And so this is a leap forward. Previously, we were talking about performing titers to confirm immunity. That recommendation from CDC has come without the necessity to confirm that someone vaccinated has indeed what we call seroconverted, right? That they have immunity. So with that being said, it does introduce the likelihood that an individual who has been vaccinated that falls into either that 5% of people, if it's Moderna and Pfizer, or if once we get to other vaccines like AstraZeneca or even the Novavax, may have up to 10 to 15% of individuals, in some cases even 30, if we're talking the Johnson & Johnson one-shot dose, that don't convert over into immunity after vaccination. And if the recommendation continues from CDC that those individuals don't need to quarantine, we need to have strategies to help in that consideration. And we know that some employers will not likely move in that direction, and we'll continue to opine about best practices as we start to have introduction of lower efficacy vaccines as we move forward. Then risk of contracting, as we talked about last week, low. Risk of transmitting is still low, and gatherings without social distancing measures still not recommended. So jumping into the process for long-term prevention in regards to the fitness for duty process, right? We want to touch upon that again because we're seeing this play out more and more in our workforce groups that we're helping, right? Where individuals are maybe not necessarily gaming the system in terms of screening out, but we're seeing more and more individuals with recurrent symptoms and recurrent absenteeism as a result of their encounter with COVID or potential encounter with COVID. And so we want to make sure that you have the strategy to do fitness for duty in partnership with what we do in terms of our overall approach. And again, it's really straightforward in terms of looking at those factors of persistent symptoms, recurrent symptoms, prolonged positivity, repeat quarantines, and any limitations an individual may have after recovering from COVID-19 infection. And if we walk through that process, again, not too foreign from what we do with traditional fitness for duty with regard to examining case by case what individual may be suffering from underlying condition versus SARS-CoV-2 infections, et cetera, and then making a determination of their fitness to participate in their regular duties. But we want to, and again, if we look at some of the other factors, the causality piece of it, the specificity of their symptoms and pre-existing ongoing workplace transmission risk, as well as pre-existing risk factors for prolonged quarantine, right? Then those are all considerations that will be helpful in determining finally that level of fitness for duty by your clinician, right? But before we get to this level, there are some strategies that we're beginning to implement with some of our partners that help flag these individuals, right? And we want to talk about those briefly here as we wrap things up. So when we look at fitness for duty analytics and potential to capture and to reduce absenteeism here, we want to talk about these levels of analytics that first talk about frequency of screening out, right? So if someone is screening out over and over. We want to start to capture those individuals that are a standard deviation or two away from the mean. And so if we look at some of the data from one of our partners here, 1.4 was the average in terms of screening out in the population with a standard deviation of 0.8. So just over 3, if we look at that standard deviation there, is where people lay in terms of the population. So the threshold being 4 or more screens would then trigger a case-by-case investigation as to, hey, what's going on? Doesn't not automatically mean that person needs a fitness for duty, but we start to have some of the data to understand who may or who may not need a deeper dive. And again, that's relative to screening out in the previous 90 days, 4 times or more. Nurse interviews that have been cleared repeatedly. Again, this data set looked at 1.3 as the average, standard deviation of 0.7. So the threshold being 3 or more clearances in that 90 days, previous 90 days, would trigger a case-by-case investigation as to what may be going on. And then finally, any reports from our clinical staff, our physicians, that where we have a case-by-case discussion with an individual around, hey, doc, can you just keep me out? Or can you, take me off work because of X, Y, and Z for non-medical concerns, et cetera. That too may also be concerning from a fitness for duty standpoint. And so we have these considerations, again, trying to be on the leading indicator side of preventing absenteeism as a result of any true underlying problems that may exist for an individual, or scenarios in which individuals are taking advantage of the process and leading to more absenteeism. So we'll stop there. I know we covered a lot, and we'll dig into questions so we can help elucidate some additional strategies here for you. Thank you so much.
Thanks, Dr. Harris. It's interesting, this week we have quite a few questions about the data that you always present, but need a little bit more interpretation. So let's take those first, and then we have some other questions related to the latter half of your presentation. Why do you think the case rate is dropping in the US and internationally?
Sure. So if we hypothesize why it's dropping, one of the hypotheses out there is that the incidence is decreasing because the prevalence is so broad. And when we talk about the prevalence, there is the observed or verified prevalence, and then there's the presumptive prevalence from an uncaptured standpoint. And if we reflect back, and we can provide an update to this next week, if we reflect back to that seropositivity data, we saw in some cases states experiencing a seropositivity of 10, 15, and in some cases over 20% of the population taken in those samples being positive for having had a past infection of COVID-19. And if we then carry that across the board, we now estimate that a far greater number of people, up to 8 to 10 times number of people, have actually recovered from COVID-19. And if that being true, that pool of people not being in the group of susceptible individuals any longer, and thus decreasing the incidence overall. And that may have a definitive role in when we get to that herd immunity number, in conjunction with the millions that have been, tens of millions that have been vaccinated, right? And we've already started putting together on my end some of that data to try to understand natural immunity versus vaccinated immunity. And we'll look at then what that means for herd immunity here in the US and then abroad in terms of a timing perspective.
Yeah, we'll look forward to that at a future webinar. This is going to be a great topic. Similarly, regarding the case rates, someone else wants to know why the amount of testing, the rate of testing, has dropped in the United States in the last few weeks.
That is a great question. And as of right now, we don't have any great answers as to why the testing has decreased. When we look at the rate of increase in number of tests months ago, it was very likely that we were going to finally hit the numbers that we all desired, right? 2 million tests, 3 million tests on a daily average, right? And we just never got there. And what we saw is a contraction. One of the thoughts is that from a manufacturing supply standpoint, we've just outstripped the resources for testing in laboratories, meaning the reagents necessary to do PCR testing are not available. The other can be associated with, again, if we look at those individuals actually showing up to be tested, right? And so if we presume, and this may actually be the picture, right, that's playing out, if we presume that a far number of people are contracting COVID-19 and recovering, right, they're not showing up to get tested because they felt symptomatic and they're all better. So their concern around COVID-19 is not as great as historically suspected. And so if participation in testing is lower, then our total number of testing will be lower as well. So so these numbers don't necessarily speak to our capacity to test. And perhaps we can elucidate that number more fully in a week or two to come in terms of capacity versus overall number of tests conducted by means of looking at participation versus true capacity. I think that may be important for us to examine. So great question.
Okay, sounds good. How do you explain the effectiveness of controls of the spread of infection in India, which basically appears pretty much as a flat line compared to other countries in the data you've been showing the last few weeks?
And the question is specifically how to give an opinion about the.
It's so effective. Like, why does it seem they're so much more successful compared to other countries in controlling the spread of infection?
Sure. So if you speak with professionals in India, the suspicion is not that India is doing a tremendous job at prevention, rather that it's in a situation where they're not actually capturing the number of tests or the number of positive individuals, right? And so if we look at some of the positivity rate there in India, we saw it peak back in November. It is declining slightly here, but one of the suspicions is that the broad testing is just not there per population. So if we look at India in terms of tests per 1,000, they're at the bottom, right? And so we know that likely is an indication that they're just not capturing the total number of infected people to the extent that other nations are that are here, well over, 10, well, historically well over 10 new tests per 1,000 people. So it's most likely not controls, but just accuracy of understanding incidence and prevalence.
Okay, and one more question about the data. Does the testing data include all types of tests, home versus lab, or is it just tests that are produced by a lab results?
Yeah, so this data is coming from laboratory results, not home testing or instant tests in which it's direct to consumer. So these are laboratory results being reported up by organizations that are charged with and obligated to report.
Okay, we have time for a few more questions. What's your opinion regarding requiring quarantine of employees who tested COVID positive within the last 90 days when they are identified as a close contact of a new COVID positive person? Is this 90-day quarantine recommendation excessive action, or is it warranted?
So we agree with the recommendation that within 90 days after recovering from COVID-19, an individual should not require quarantining with any subsequent exposure during that time period. Outside of that time period, however, it is recommended to have them quarantined because of the increased risk of reinfection going up, right? And so when we talk about the longevity of immunity and updating in that regard, again, 5 to 8 months is what we believe is imparted from natural immunity at this point in time. So we may see a widening of that recommendation or a lengthening of that recommendation of 90 days. But as of right now, it's still that 90-day window after recovery from infection, as well as those individuals who have been vaccinated with a full series of vaccines, whether that's the one dose with J&J or multiple doses with the other on the market.
Okay. This question has a comment first. I understand that the vaccine's effectiveness is related to a short-term measure, but shouldn't safety be evaluated? What are the long-term impacts regarding the safety of the vaccine?
Sure. If we're speaking to the vaccines approved for emergency use authorization in the U.S., particularly the Moderna and the Pfizer vaccine, you're absolutely right. We don't have any long-term data on the vaccine's safetiness. The short-term, obviously understood from immediate response after the vaccine administration within 30 minutes being equivalent to that of placebo at less than 1%. But if we look at what happens over long-term periods of time, we're talking, a year or more period. We just don't have that data yet, but we will soon for the phase 2, phase 3 clinical studies that kicked off beginning of last year as we approach that annual mark here.
Great. Let's just take the final question and then we'll have answered all of them this week, which is great. How does the Cal-20C variant compare to other variants? It's up to 40% of all cases in Southern California and has been detected in at least 19 states. It doesn't seem to be getting as much hype as other variants. Why is this, since it's already here in the US as in a major proportion of cases in California?
Sure. So that particular variant, we have evidence to show is not necessarily increased risk for reinfection, meaning that it evades the immune system, nor do we have any evidence that points towards it being more of a poor outcome determinant. So right now, in terms of that Cal variant, we're still watching, we're still looking for new data, but we haven't seen any data that points towards its increased transmissibility versus, severity. And that's obviously a good thing, and maybe why it's not getting as much press as some of the variants in which we do have data around severity, poor outcomes, as well as increased transmissibility.
Okay, that wraps up for this week. Next week is week 50. So we're getting very close to our goal of 52. Want to remind everyone you can send us questions in advance if you like, so that we can weave them into the presentation. Thanks again for joining us. And as always, thank you so much to Dr. Harris for his expertise. See you next week.
Thanks, everyone. Stay safe and God bless.